I'm going to talk about COVID for a sec, but we're not talking about COVID today. There's a peculiar phenomenon with this virus that we've been seeing ever since the pandemic began, a phenomenon that's incredibly alarming and worrisome when we think about all the community dwellers who feel their symptoms are mild. It's kind of like hypertension in this way. There's no way you'll know you have uncontrolled blood pressure until it causes something serious, a heart attack, a stroke, kidney failure. With this novel beta coronavirus, one of the most common symptoms is hypoxemia. Luckily, many of us feel short of breath when our oxygen levels fall and our carbon dioxide levels rise. There's a compensatory response to this physiologic perturbation. Chemoreceptors in the ventral medulla respond to the increasing acidity in the blood as carbon dioxide levels rise. And there are other sources of feedback as well that regulate unconscious breathing. But let's think about these chemoreceptors in the medulla and respiration. With COVID-19, we know from at least one well-executed autopsy study by Matschke and colleagues that SARS-CoV-2 directly infects neurons and glial tissue in the nervous system. In their post-mortem series of 40 patients who died of COVID-19, SARS-CoV-2 viral proteins, or viral RNA, was observed in the brains of over half of these patients, with a high burden in the medulla, where our respiratory centers are. Now, there's still a lot that we have to learn about this virus, but maybe this explains the alarming phenomenon we've observed in patients with COVID-19. Patients come in with mild to moderate disease, unaware of low oxygen levels. It's called happy hypoxemia. Feeling otherwise pretty well, patients are coming in with SpO2 levels of 90%, 80%, not adapting to the low partial pressure of oxygen circulating in their blood. The whole process reminds me of agnosia, which, broadly speaking, is the inability to register and respond to sensory input. In many cases of COVID-19, patients are not physiologically or subconsciously registering low oxygen levels. In agnosia, patients are not consciously responding to stimuli that they otherwise should be. So this week on Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it, we're pivoting from the happy hypoxemia of COVID-19 to the blissful negligence of agnosia. Only we think ignorance is bliss. I'm Jim Siegler. Don't go anywhere. Oliver Sacks, the famed British neurologist and historian, and author of The Man Who Mistook His Wife for a Hat, actually suffered from prosopagnosia, an inability to recognize faces.
I see all the features, but it doesn't quite add up to a unique image from a...
Now, this is different from the prosopagnosia of COVID-19, where we're all struggling to recognize our friends and colleagues by their eyes and their personalized face masks, or the prosopagnosia you may have diagnosed yourself with in medical school because you sometimes have trouble remembering the face of an old friend.
You may see a face perfectly clearly, but it doesn't convey identity to them.
Oliver Sacks recalls being unable to recognize a personal assistant of his who worked with him for years.
Because I often don't know whom I'm talking to.
As a younger man, he wrote about how he had learned to recognize people based on the thickness of their eyebrows or their hairstyles. You can imagine that such an impairment could be as mentally distressing as it is physically disabling.
Yes, I've occasionally started apologizing to a clumsy, bearded man, only to realize that this is a mirror and this is my reflection.
Historically, disorders like agnosia and apraxia, disorders of higher-order neurologic function, had attracted much interest to clinicians and neuroscientists, and in spite of many ongoing nosologic debates, there are certain key facts that you should take away from our present understanding of the agnosias. First, an agnosia can only be determined after exclusion of impairment in sensory function. This may seem intuitive, but we should be clear about the distinction between agnosia and low-level receptive disturbances. A patient who has a severe diabetic neuropathy, for example, who has near total loss of sensation in their hand, cannot have a tactile agnosia when they cannot feel an object to begin with. Similarly, a patient with age-related macular degeneration may not be able to recognize faces because of poor visual acuity, and this is not a visual agnosia. Second, agnosias are traditionally categorized by the sensory system that's affected, the modality, which has implications with respect to lesion localization. As an example, the patient could have a dysfunction of sound processing. Pure word deafness is one of the better-known agnosias that affect auditory information. usually attributed to bilateral lesions of the primary auditory cortex or lesions of the dominant superior temporal gyrus. Pure word deafness is just as it sounds. A patient can hear sounds, they can recognize a car horn or a dog bark, but spoken language conveys no meaning. In this way, pure word deafness can be distinguished from a generalized auditory agnosia, in which the patient cannot recognize the car or the dog. Of the other sensory symptoms, visual agnosias are actually the most common. As Dr. Sachs experienced, a patient could have prosopagnosia, or face blindness, or an object-specific visual agnosia, such as the inability to visually recognize tools, although the patient may recognize pets and people perfectly well. I'm sure this audience is familiar with the next condition, alexia without agraphia. But rather than being a disturbance of language function, it's more of a visual word agnosia, pure word blindness, as it's sometimes called. These patients cannot understand written language, although they may copy letters and numbers, but they can perfectly understand spoken language, and they can typically converse quite normally. The examples we just went through, pure word deafness, prosopagnosia, and object-specific visual agnosias, these are all largely classified in the camp of aperceptive agnosias, as originally described by the German neuroscientist Heinrich Lissauer, which is to be distinguished from the associative agnosias. Think of it this way. Agnosia refers to the problem in which we think about a physical entity, how we translate the sound of a bird chirping into the mental construct of bird, nest, eggs. An aperceptive agnosia is an impairment in the first step of stimuli processing, where the bird chirping is just noise, while an associative agnosia is an impairment in that second step, in which bird chirping can be appropriately contextualized as a sound you might hear outside, or a sound heard in the middle of the day, a pleasant sound. But the idea of the bird won't register. Think of an associative agnosia as a normal percept stripped of its meaning. It's probably easiest to distinguish aperceptive from associative agnosias visually based on the patient's ability to copy the stimulus. When asked to copy an image of a record player, the patient with an aperceptive agnosia will be unable to do this. The image as a whole won't register to them. Conversely, the patient with an associative agnosia may be able to copy or draw an object, but they can't tell you what it is. A record player. In this example, a patient with an associative agnosia could visualize an object in space. They could understand its purpose, know its shape, know the variable ways that it may look, know an object's taste or smell, and so forth. But they can't for the life of them name the object. This type of a linguistic agnosia is also called an optic aphasia. Visualizing a flower may prompt the patient to describe how it grows, its water requirement, or elicit memories of a romantic moment. But a patient with a visual agnosia for flowers won't be able to name it. The flower. And here is where the nosology becomes complicated. For example, how is an optic aphasia differentiated from an anomic aphasia, or visual agnosia? The key is in its modality specificity. An optic aphasic can be handed a flower. They can touch it with their eyes closed or smell it, and name it with greater ease than if the patient were simply visualizing the flower at a distance. And as I had mentioned earlier, this has implications for lesion localization. With preservation of naming, when there is the use of other sensory modalities, the dominant hemispheric language centers, the left frontal and temporal lobes, are often preserved. It's the association cortex that bridges the visual and linguistic centers that are affected by an optic aphasia, for example. To distinguish an optic aphasia from a visual agnosia, as we continue to explore the flower example, this is an aperceptive impairment rather than an associative impairment. The patient cannot visually recognize the object in its entirety. A visual agnosic can describe the curves of the petals, the color, the leaves, and the stalk, but they will not be able to name the object as a flower, and unlike the patient who's an optic aphasic, they won't be able to tell you the scent of it or describe where you might find it. Again, much of these semantics remain controversial, as some cognitive neuroscientists have debated whether there's even a difference between an optic aphasia and a visual agnosia. Such clinicians believe an optic aphasia to be a milder form of a visual agnosia, in which object purpose and characteristics are preserved. Also, there's a tremendous overlap between agnosias and other cognitive impairments. Rarely do they occur in isolation. A patient with Riddick syndrome, for example, which is a form of a visual hemifield agnosia, often due to a unilateral lesion of the primary visual cortex, that patient with Riddick syndrome is likely to have some sort of a visual field impairment beyond just the blind sight that's ascribed to this condition. As you may know, and as we've discussed on this podcast before, the patient with Riddick syndrome may be unaware of an immobile object in a hemifield, and yet when it moves, the patient will sense there to be motion present. Even so, there's likely to be a region of the visual field where perception of motion remains impaired, as well as perception of lack of motion. Similarly, a patient who has pure word deafness, who feels that spoken language is white noise, they're also likely to have some impairment in speech production. There's simply too much overlap in the neurobiology of these sensory and association centers. All this being said, what does this mean for our patients with agnosia? How do they compensate for these distressing and disabling cognitive deficits? As for the first question, agnosia most commonly surfaces in patients referred to neurology because of an underlying degenerative condition. Visual agnosias, which are the most common, are typically seen in Alzheimer's disease and frontotemporal dementia. Many of these patients have posterior cortical atrophy, as you might expect, which is associated with Alzheimer's disease in 2/3 of cases. But with PCA, you should also be thinking of dementia with Lewy bodies, corticobasal degeneration, and Creutzfeldt-Jakob disease. Bilateral posterior cerebral artery infarctions are also a common cause of a visual agnosia, and for these reasons, neuroimaging with MRI is recommended to rule out structural pathology. With bilateral occipital and occipital parietal injury, if the patient has preservation of sight, you might find that these patients have a specific visual agnosia referred to as simultagnosia. At a community playground, for instance, they might see a swing or a merry-go-round, but they won't report being able to see the slide or the basketball court in the distance. These objects are within their field of vision, they could see it, but the deficits lie in attending to more than one visual stimulus at a time. And to answer that second question, how do patients compensate with their disease? Well, the brain is an amazing organ, and it's far more sophisticated than we presently understand. Dr. Jeff Aguirre and I spoke about this for a while on top-down processing back in episode 117, and you should really check out that program to better understand what I'm about to wrap up with. In the absence of useful sensory input, as in an aperceptive agnosia, or in the absence of integrative faculties where sensory input intersects with the previously encoded information, as in associative agnosias, without these processes intact, the brain falls back on the next most reliable sensory percept, or previously stored data. And what this means is, for a patient who has pure word deafness, they'll often describe, in written format, that they rely on intonations in speech, speech prosody, and elements of body language in order to understand what's being spoken. They cannot interpret the semantics of spoken language, so they unconsciously rely on the affective prosody of language and physical gestures, and of course, lots of written communication. Personally, I find all of this incredibly fascinating. Agnosia, awareness, higher order mental functions. This is the romance in neurology. Sure, we get the brain MRI, or the spinal tap, or the EEG, and these tests help us better understand the why. But it's the what, it's the how that opened the door for many of us. And hopefully, after today's quick and hopefully not too dense review of agnosias, we haven't taken the romance out of neurology for you. That's it for another week of the Brainwaves podcast. Thanks so much for tuning in. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision making. This week's episode of Brainwaves was produced by myself, Jim Siegler, at a Studio 3 in Philadelphia, Pennsylvania. Music for today's program was courtesy of Dr. Turtle, Grossman, Ewell, and Granger, Marco Trovatelli, and Purple Planet Music. Our theme song was composed by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information about what's discussed on the show, as always, please take a look at the references in the show notes for all the literature that was reviewed prior to the generation of this episode, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler, and I'll talk to you again soon.